Dysphagia, why worry? You still see that okay? Yeah?
Yes, it's
fine. Something happened to my screen which gave me a bit of a concern. Fine. So I think over you know me, I'm Professor of Pharmacy Practice at the School of Pharmacy, University of East Anglia, and this is a talk I've been giving this year across the country, and I apologise, I should have put that I'm also a Professor of Clinical Pharmacy at the School of Pharmacy at the University of Bergen. So what I'm going to go through, just tell you a little about myself so you can see where I've come from and why I'm doing this work. Talk a bit about dysphagia and aspiration pneumonia and why, as a pharmacist, we probably do need to be aware of this. And this was all kind of a revelation to me when I got working in this area. Talk about tablet crushing and why we shouldn't do it, and the issues that causes with medication errors. And the last thing I'll talk about is thickeners, because this has actually become quite relevant recently. As international guidelines for thickening foods and liquids have come out, people have started asking the question about thickening tablets and liquids and such like. And then I'll obviously summarize. So we've done that. Let's go on to my personal history. So I was a graduate in 1992 from the University of Bradford. It's a northern city, not quite as wet as Bergen, but quite a cold city. But I was one of those strange pharmacy graduates, very strange in England, who did 6 months in hospital and 6 months in community practice. So I worked in both areas, and that's unusual in the UK. Most people will do 12 months in one area. In the last few years, that started to change, and people are starting to do slightly more split placements. But the reason I went to Bradford was that it put the training within the degree, and therefore I got to work within both areas to decide where I wanted to go at the end. So, which is obviously academia. But to be honest, I was a community pharmacist until about 6 years ago when we had twins, and I was told I had to stop practicing because I had to spend time, and rightly so, with my family helping out. So as I say, stopped in 2016 practicing fully, and then I did my PhD a few years after graduating in clinical pharmacy services in care homes. So in the 1990s, we recognised that care homes needed greater input from pharmacists, and so I ran a trial where I provided care to 20 homes in Bradford and had a control arm of 20 homes in Leeds to see what the impact was. And wasn't the best study, and the worst way to do research is to evaluate your own service, so that never really got highly published or cited. But I then went on to become a lecturer at the University of Bradford, and by accident, I had this interest in dysphagia started in the year 2000. A master's student, and it was a postgraduate master's student, came to me from hospital saying, I'd like to do a master's, could you supervise me? And I'm really interested in tablet crushing because in hospital, we're getting lots of questions about it, and I want to know what's going on in the ward, and I'd like to do some research. And I said, actually, well, I work in care homes largely, and my experience in care homes was of tablet crushing, but I never really thought a lot of it. But actually from there sparked the research that I've been doing for the last 10, 15 years. I moved to the University of East Anglia in 2003. And that was because it was set up by pharmacists to deliver a school of pharmacy. And so, you know, we broke the mold with that school of pharmacy in the UK. We really put pharmacy practice and clinical pharmacy from day one, year one into the degree, and got our students out into practice in the first or second weeks of their degree placement. So it was quite a different degree to what was going on in the UK at the time. And fortuitously, really fortuitously, one of the best things that happened in my life was this relationship we built with the University of Bergen from the year 2006. You'd set up your own school of pharmacy exactly the same time, or might have been a year before or a year after, and we're looking for some help with some pharmaceutics teaching. And at the University of East Anglia, we had a strength in that, but you've got a gap, and so you asked for a bit of clinical teaching, which I took responsibility for, and that has worked really well. And once that contract finished, you kept me for your sins as part of the team. So let's talk about dysphagia. First of all, the actual term, the scientific term, means physical problem with swallowing. And it's commonly associated with all of these conditions: stroke, dementia, Parkinson's disease, learning disabilities, GORD, gastroesophageal reflux disease, and aging itself. In stroke, 70% of people who have a stroke will have dysphagia within the first 24 hours. And between 8 and 10% of people with stroke will have permanent dysphagia, which means then they will have problems swallowing food and liquids and taking medicines. Dementia, it increases dysphagia as the disease progresses to beyond 50% of people with dementia get some form of dysphagia. Parkinson's disease is beyond 60%. Learning disabilities, which really surprised me, this, but 20–30% of people with learning disabilities have some form of dysphagia. GORD actually causes it because it causes inflammation in the esophagus, which narrows the lumen, narrows the space, and people with GORD will very often describe tablets sticking at the back of their throat. And they're not sticking, they're just lodged because they can't actually pass down the narrowed tube. And aging itself makes the muscles weaker, makes us produce less saliva. And you'll notice, particularly older people will spend a lot longer time eating because they need to chew their food more and spend more time before they can swallow it. The term swallowing difficulty I use to encompass both dysphagia and psychological aversion to swallowing tablets, because there is a percentage of the population who just don't like swallowing tablets. So I use the word swallowing difficulty to encompass both of those. But you look at those conditions, you can see that this is definitely a condition of aging, and definitely some, particularly in care homes, is incredibly common. About 30% of residents in care home will have some form of dysphagia. And in the hospital, I know you have a medicine information service in Bergen, and we do in all our hospitals. And the most common query from the wards in the UK is, can I crush this tablet? So the first thing that really shocked me coming into this area was the fact that it's not about medicines, dysphagia. It's about social life. You take away someone's ability to swallow or make swallowing difficult, you take away the reason for living for many people. You know, I think about everything I do that I enjoy doing focuses around eating food and drinking alcohol or drinking generally. You know, and you take away that, make that more difficult, that suddenly reduces your quality of life dramatically. From a medical perspective, it's nutrition and hydration that are the priority. So we in the UK, and I think you have the same in Norway, you have people who are experts in dysphagia assessment, swallowing assessment, and they will decide what's appropriate for that patient, where the dysphagia is and how best to deal with it. But they focus on food and liquids because it's really important the person gets their nutrition and gets the hydration. What people forget to do and fail to think about is the medicines. And with all those conditions I showed you earlier, there are large numbers of medicines. And so there is somebody at the end always having to give these medicines to this person who's struggling to swallow. And that's why I want to talk about, and that's why this talk is about trying to get people to raise awareness and expectations with regards to medicines and not just treat them as the third party in this process. So the next thing I learned, apart from this thing, you know, it's about the patient, it's about social life and nutrition, hydration, and medicines come down the list, is dysphagia is very closely associated with aspiration pneumonia. What that is when you swallow stuff into your lungs rather than your stomach, you generally swallow stuff which has got bacteria or viruses in it. Most food, most liquids we take are not sterile. Most medicines we take are not sterile. Anything that goes into the lungs, which shouldn't go into the lungs, causes aspiration, and repeated aspiration is very closely associated with pneumonia. And pneumonia, if you look at Parkinson's and dementia and all those conditions I showed you on the last page, pneumonia is the most common cause of death, or the second most common cause of death. Really surprised me, but there was a real strong feeling, and the evidence suggests this, that dysphagia really enhances the chances of early mortality, and early mortality due to pneumonia. And what's interesting to me is we spend all our time getting the right food and liquid for a safe swallow. We forget the medicine, and I do wonder how much medicines can contribute to that mortality because people aren't thinking about it. So let's just look at the swallowing physiology. We don't do physiology in pharmacy in England. I don't know whether you do. I'm guessing you don't do a lot of it in Norway either, because it's not really the pharmacist's expertise. But if you think about the swallowing process, it's not very clever. We have to take air and food the same route, and there's just one little flap, the little flap there, the epiglottis, that ensures food or liquid goes in the right direction. Any fault with that, you get aspiration. If that doesn't close autonomously and perfectly, then food will go into the lungs. So that's the first thing, aspiration. But what most people worry about is obviously choking or asphyxiation. And what they're worried about here is some bolus sticking here. between the tongue and the back of the throat, because that means then it doesn't matter they can't swallow the food, they can't breathe and the air can't go in. And so it's the choking that very often worries a lot of people and makes it difficult to swallow when they're struggling to control the bolus in their mouth. And I would say, if we're going to become X-Men and we're going to take that second step forward in design, if it was up to me, I'd just seal this with a bit of super glue and I'd just stick a hole here. And then that way you can eat and drink as fast as you want. You never need to stop, and you can talk at the same time, provided we move the vocal cords down as well. But that would be far safer than what we have at the moment with this design. So when you talk about swallowing, there's 3 phases. There's the oral phase, pharyngeal phase, and esophageal phase. There's other ways people break it down. Some break it down into more phases. But I think this is the easiest way to look at it. The oral phase is where you break the bolus into a size that's safe enough to swallow so you don't choke. But equally, you add saliva to it so that it lubricates it so that it doesn't stick. So any damage or any problem with musculature in the mouth or the hard palate at the top can make it difficult to form that bolus and then make it a safe swallow. This is the pharyngeal phase. The second phase is the one we're most worried about because that's where the epiglottis comes in, and we're worried about aspiration and we're worried about choking. And then the third phase is the esophageal phase, and that's where GORD causes the problems by narrowing that tube. So I thought I'd share you some videos I've got of swallowing. This is a normal swallow, and you'll see very nicely how the epiglottis closes. There you go. Beautiful swallow. What's interesting, however, is this little pocket here. You can see this, and it's shown in the other ones as well. And it serves no purpose, but this is where tablets. Yeah, this is where tablets can get lodged, and this is why whenever you tell someone to take a tablet or a capsule, you actually say to them, take it with a glass of water to ensure that it doesn't stick here, because there's certain tablets and capsules, such as antibiotics, which can cause erosion and ulcers in the throat and in the esophagus. So this is someone with Parkinson's trying to swallow. And what you can see here is they are really taking their time and letting small amounts down, probably because they're worried about choking, but equally they're worried about aspiration. And you can see now the liquid, because it's being pushed down bit by bit, is actually sitting in that little pocket there. And and with the Parkinson's, it's the control of the tongue. I'll just show you that again. It's quite painful to watch, really. It's the control of the tongue that's the problem, and the ability to get that to move in the way they want. And so they're actually just pushing very small amounts down. But that person needs a very different texture to the person you saw first of all who could swallow perfectly. This person definitely needs thin, runny liquids. And I'll show you the next one. So this is someone who's actually got aspiration and their epiglottis doesn't work. You watch here. There you go. Straight down into the lungs, and they go straight forward to cough. I'll just play that again so you can see that. Now this person needs something, there it is, straight into the lungs, full of bacteria, chest infection, there you go. This person needs something thicker. They need something where when they swallow, holds together and doesn't split, and therefore becomes a much safer swallower. So it's really important with dysphagia that you know what the nature of the dysphagia is, where the problem is. Is it the mouth? Is it the pharynges? Is it the gut? Is it the esophagus? And therefore, what texture do we need? And what's the best way to give the food and liquid? And then after that, what's the best way to give the medicine? And actually, is it much safer just to avoid the oral route altogether and find another way of administering the medicine? So what I say is the presence of dysphagia is one of those points when it first appears where you need to take a different view of the medicines and you need to make a risk assessment. I think actually is what's important to the patient now. What's the risk of carrying on taking all these medicines? Which of these medicines are going to improve the quality of life? Which of these are going to improve the chance of aspiration, or are not really going to provide a benefit? So the sort of things you might think about is just statins. We know you need to take 50 people need to take a statin for one person to benefit, in 5 or 10 years' time. This person's now got dysphagia. By adding a statin tablet in, and increase the chance of aspiration, what's the risk and benefit now? And probably the risks are greater from continuing to take that tablet or even that liquid rather than not taking it at all. So I think the questions you have to ask at this point, and this is what I did in my care home work, was, is this really effective? Is it doing what we think it is? Is it still working? Is it causing side effects? And that was one of the most common issues I came across in the care home. I'd find 2 medicines, one to treat a condition and the second one to treat the medicine that was treating the condition. The best example of that I came across was a person who's given haloperidol 1 month, and then a doctor came out 3-4 weeks later and started them on levodopa, not recognizing that it was the haloperidol that suddenly created the Parkinson's symptoms that was creating the need for the levodopa. So that, and these sort of things doctors don't pick up on, because very often they're not the same doctor, but equally they don't think about the medicines, they think purely about the patient. And the nice thing about pharmacists is we think more about the medicines. And then obviously if they still need it, it's still effective, the benefit's immediate, and it's going to improve their quality of life, is this the best formulation? And has it got the right thickness? But important here is, what's important to the patient at this stage in their life and disease progression. And so I have developed in England some national guidelines for administering medicines to people with dysphagia. We got a group of experts, lawyers, doctors, nurses. I chaired the group, and we came up with what's like a flow chart, but also lots of common sense advice. But the first thing we say is the medicine still needed? That's the first question to all, because it's much better just to stop it rather than continue it and then increase the risk of other problems. So let's look at tablet crushing, because this is what happens. Person's got dysphagia, we've got to give them the medicine, and then someone has to then, decide whether to crush the tablet or do something else with it. So we did a survey in care homes to ask them how often they crush tablets. That was with that master's student. And we had 540 nurses complete the survey. These were study days across the country. And what shocked me as a pharmacist was how often this was happening. 40% of them said every drug round, I will crush tablets for one of my residents. 29% said every day, another 12% weekly. And this 19%, I think, knew what I was asking and knew to lie. Because now I know what really goes on in the world, I realize actually this is more like it. And actually within a care of the elderly setting, crushing tablets is ubiquitous. My first ever paper that was of any note has ever been cited regularly, but no one had asked that question before, and there was a real shock to the system when we realized this was standard practice. And this is why it shocked me, because like yourselves, we spend a lot of time in the laboratory learning about the beautiful tablet. And that tablet isn't just the drug, which is what most general public think. And if you ask a nurse, very often they've had no training in pharmaceutics, and as far as they see it, that's paracetamol. There's nothing else in that at all. It's a simple drug. Crush it up, they're still going to get the same thing. What's the problem? And what you and I all know is it's all these things. It's the active ingredient. There's a filler, which is there to give it its size, because very often the active is so small. If you just did that, it'd be too small to actually manipulate. You start putting 2 powders together, they're not going to stick together naturally, so you have to stick a binder in. You stick a binder in, they may not break up, so you then have to stick a disintegrant in, which reacts when it's in the right pH. You then got to get these powders moving around the tablet press, so you add lubricants, glidants, anti-adherents in there, and then equally you might have some flavorings and colorings as well. So that little white tablet has a lot of ingenuity and a lot of thought, and it's just even the way those things are pressed together, and the pressure on there affects the way the drug is released. And even cleverer than that, they've selected all those things to make sure they don't affect the active. Because we know there's lots of different fillers you can use, lots of disintegrants, lots of binders, but you've got to choose the right ones so they don't stop the active from being absorbed. And that's how much thought has gone into that simple white tablet. And then what you see is a nurse either dropping it in water, which is not designed to be dissolved in, or just hitting it with a pestle and mortar. So I've talked enough. Let's now try the quiz. I'll move you on to the next question. But the question is, by someone having dysphagia, what is the increase or reduction in the medication administration errors on the ward? 10% less, no effect on errors, 10% increase in errors, 150% increase, or 300% increase. Have a go at answering one of those on Socrative. Okay. 8 of you confident to give an answer. Let's have a look how you did. Okay, well, at least you're sensible enough not realize it doesn't reduce the chance of errors, and actually it does have an effect. And actually 150% or 300% are correct. It's a real massive impact on error rate, and I'll explain that now to you. I had a PhD student who was a nurse who worked with me for a number of years, Jennifer Kelly, who was brilliant. And one of the things she was really upset about was tablet crushing and how nurses weren't trained about it. And so she actually went out as part of her PhD and worked on 4 hospitals, 8 wards, driving around Norfolk and East Anglia, broader than that, going to different hospitals to watch what went on the ward. She watched 2,000 drug administrations over a 6-month period. Within that, this is why you don't want to go into hospital in the UK, 817 had an error, okay? Although dysphagia patients were only 20 or 30% of those, you know, of those 817, 313 involved people with dysphagia. She went on wards were for older people and stroke wards, so we knew dysphagia would be prevalent there, and that was the point. We were trying to work out whether medicine administration was any different for those people with and without dysphagia. So if you haven't got dysphagia, your chances of an error of some sort was 14%. So 1 in 6, 1 in 7. If you've got dysphagia, your chances are 33%. So you can see that's a 150% increase. If you have an enteral tube, your chances are 56%. So every other drug had an error associated with it. And reassuringly, many of these errors were very minor. A lot of them were just sort of late dose errors. But there was a phenomenal amount of errors, and just by having dysphagia or not being able to swallow tablets normally or give them on the normal route massively increased the chance of errors for that patient. And what was clear was it wasn't deliberate by anybody. What was happening was the doctor would write the drug and the dose on the chart, or it would be electronically nowadays, and then the nurse, when going around, would then have to make a decision as to how best to give the tablet to that patient or the capsule, because that's what they'd been supplied up from the pharmacy, and they're suddenly faced with someone where this may not be the best formulation. And so they were always operating the best interest of the patient. They knew they had to give them the drug, they knew they had lots more patients to see, they knew they had a limited period of time, so they made decisions. And we saw not only mistakes, you know, with patients, but we saw the same patients having the medicines from 2 different nurses, and they get them in 2 totally different ways. We had a separate publication just analysing those 2 different experiences that same patient had. You can imagine that patient leaving the hospital haven't got a clue what to do with their medicines, because every time someone gave them a medicine, they gave it to them in a different way. The 150%, 300% increase in error. And why is that important? It's to do with the Swiss cheese model. I'll come back to that in a second. So we found patients chewing modified release medicine. So they hadn't picked up they had dysphagia. But when they looked at them and realized they were chewing absolutely everything, they couldn't swallow anything whole. And as we know, modified release should be swallowed whole. 24 cases of medicines being crushed. None of those were modified release, thankfully, but all of them without the doctor's authorization. And in the UK, the law is very clear. You have to give the medicine as it was designed by the manufacturer. Once you alter that medication, then the manufacturer takes no responsibility unless it's designed to be altered. And the only person who's allowed to authorize alteration is a doctor, or in the UK, a prescriber, which could be a pharmacist or a nurse as well. So if you're a nurse and you're not a prescriber and you're in front of a patient, you crush a tablet, you are breaking the law. You do not have power to do that. And if that patient's then harmed, and there are cases of patients being harmed as a result of this, then you personally would be sued and would be taken responsibility and struck off for that. And it's just such in the nursing culture just to crush tablets, disperse them in water, that they don't think about getting authorization or sitting within the law. And in a number of cases, there were licensed alternatives. And it's very clear, our government says that if there's a licensed alternative, you should always do that rather than crush a tablet, because actually it's much safer for the patient and much safer for you. And the big problem with enteral tubes is they're just not flushed. Now, enteral tubes are the tubes that go into the stomach and go into the jejunum or through the nose, the nasogastric. And they are designed for liquids and food, and the liquids and food that go down them never block them because they are designed purely for enteral tube administration. When enteral tube blocks, it's invariably due to medicines because they are not designed to go down them, and people don't either crush the tablets fine enough, flush before or flush afterwards. And without doing those things, then the tubes cake and block. And if they block and you can't open them, you've got to go back in for another operation to have it resized. So as I said, the Swiss cheese model says that if you have loads of errors, it doesn't matter how minor they are, every so often they will line up and one major error will make it through. And that's what you're trying to stop. So what we've got to try and do is stop the culture of tablet alteration and tablet crushing on the ward and move it away from that so people ask the right questions and seek authorization before they do it. So this is a bit now about formulations, which with yourselves is teaching grandma to suck eggs, as we'd say in England, but I think it's worth just revising this. So we know we design a tablet to release the drug at a certain rate so that it gets above the bottom red line where it's like to work and stays as much as possible below the top red line where it's more likely to cause side effects. Now, thankfully, many drugs have top red lines quite high and therefore the peaks don't really matter. But we all know there's medicines out there where the peaks do cause problems, things like theophylline and nifedipine are good old-fashioned examples, which now always come modified release because of the peak effects, which really would affect the patient. Modified release, obviously get rid of those peaks because they just release the drug slowly over an extended period of time. So stay nicely within the bands of your patient. You have to take them every so often, and so you don't fall below, you don't fall above. The issue with modified release, as we know, it's many doses in one tablet or capsule compounded together. If you crush it, everything gets released in one go, and therefore you end up with very good chance of toxicity. And the one case I know about that happened in Scotland was an MST or morphine 100 milligram tablet crushed in a nursing home, which killed the resident because they got 100 milligrams of morphine within the first half an hour rather than spread over 12 hours. And what's interesting with a crushed modified release product is your liver and kidneys will speed up because they know the concentrations are higher and therefore they'll clear the drug out as quickly as they can, which means not only do you have a toxic point, but you have a subtherapeutic point for a long period of time as well. Then we have enteric coatings. And enteric coatings I always thought of as a student was purely there to protect the stomach. So I always thought about naproxen and diclofenac and aspirin. But actually, it's very often there to protect the medicine. So if you look at omeprazole and lansoprazole, which funnily enough stop acid production, those chemical entities are actually acid labile. So if you actually take omeprazole straight into the stomach without any coating, a lot of it will be destroyed by the acid in the stomach. So lansoprazole and omeprazole capsules all have granules within them, and the granules are enteric coated. So where you might be able to open the capsule, you can't grind the granules, because if you grind the granules, you will then reduce the efficacy of the drug. The other reason we have enteric coatings is to get the drug to where we want it to work. So mesalazine and sulfasalazine are good examples of drugs for Crohn's disease and ulcerative colitis. And if we want them to work lower down in the GI tract, we need to have a coating on them, which means that when they go in the stomach, they don't release. When they get into an alkaline environment, they start to release. So the concentration builds up at the location at which they want to work. So there's three good reasons for enteric coatings, all of which mean if you remove that in any way at all, you cause an adverse drug reaction and you can reduce efficacy. And then we have film or sugar coatings. And I've got a picture of M&Ms here because I think this is a funny one. M&Ms have chocolate in the middle. Why would you put a sugar coating around chocolate? Because the main reason for sugar coatings is to mask flavor. You find it on quinine, you find it on ibuprofen. Ibuprofen tastes horrible. So that's why they're always pink. They've either got a sugar coating on or a film coating on because the drug itself is really unpleasant. Why would you cover M&Ms, which are chocolate, in a sugar coating? And all I can think of, well, possibly it's about stability, because that's one of the reasons why we have sugar coatings, but I just think it's cheap chocolate and they're hiding it. And kids don't know that, and they get the sugar buzz, they get the color, and therefore they don't realise the stuff inside probably isn't very good quality. So, but if it's to mask the flavour, okay, that's not the end of the world to get rid of that coating, but it's quite unpleasant for the individual patient. The other reason for the coating is some drugs cause skin sensitization. So chlorpromazine is an example of something where you touch it with your fingers, you can get a rash. So it's not there to protect the patient, it's there to protect the administrator. And as we know, the sugar coats sometimes the environment. But you need to know why the coating's there so you can decide whether it's safe to crush or not. So when I give this talk, and I give this talk mainly to nurses actually, speech and language therapists, and occasionally to pharmacists, my main message is, look, the one person in the healthcare team who understands coatings, know why they're on the different drugs and has the expertise is the pharmacist. So if you're going to start tampering with the medicine anyway, the person you must ask is the pharmacist for advice. So just to test your pharmaceutical knowledge, let's now do the next part of the quiz and see how good you are now as pharmacists. Which of these can be safely crushed or opened? Bit more thought going into this one. No random guessing. One person so far has made a decision. Few sitting on the fence, just Googling the answer. Okay. Let's see how we did. Brilliant. So ibuprofen is safe. And actually the person who said diphenol, I'll give you that. As long as you don't crush the granules in between, then you are probably safe. And that's what the manufacturer will tell you. They'll say it's not licensed and we take no responsibility. But they'll say with diphenol, if you open the capsule but don't crush the innards, then it's safe and it will work just as well. And ibuprofen just tastes foul, but it is safe. So the other things we saw, and this is what shocked me as a pharmacist, was wrong preparation. We saw people measuring morphine liquid using a cup, not a syringe, not a spoon, but a cup, and looking at it. One of these cups is up to 50 ml. So that looks like 2.5 ml, and giving the patient morphine. This is in English hospital. I'm sure it doesn't happen in Norway. Inappropriate syringes for enteral tubes. Use the wrong syringe, you could burst them, which again means that you need to send them back and get them replaced. Obviously, we've talked about the non-flushing of tubes, but the one thing that shocked me most of all was this putting all the tablets into a pestle and mortar and crushing them together. And I'm going to give you a video in a minute to show you that. So this is a course that I've set up. It's an international course, freely available by FutureLearn, and it's called Medicines in Dysphagia. And it runs 3 times a year, 4 times a year. It's 5 weeks, 2 hours a week, costs nothing to do. But I have a load of experts do a session each week, some on adherence, some on speech and language therapy. I do a little bit as well, which I'll show you now. But a nice course. We've had over 40,000 users, and the average rating is 4.8 out of 5. So I don't think it's the worst training course. So if you want to access it, you really want to understand the topic better, then this might really go. I'm just going to play you the first bit of the video.
What we thought would be useful, just to make the point, was to show you what we saw happening to one patient on a ward when one of our researchers was watching a person administer their medicine. And what they did, they got all the tablets the person was taking and put them in a pestle and mortar. They then emptied the capsules in. And then once they'd done that, they just crushed everything up together with a pestle and mortar like this. So you ended up with a nice colourful sludge at the bottom of the dish. Once they've done that, you can see it's not that easy, it takes a while to do. And for someone like myself who spent years learning about how we make tablets and how we design them, it's very upsetting to see. A lot of thought has gone into these tablets, a lot of thought's gone into their design, and seeing someone then just mash them up into a fine pulp and crush it, somewhat upsetting, and I lost a bit there. But then what they did was add some water to it to make it into a nice palatable sludge. And once they've done that, they then fed that to the patient. How would you feel about being given those medicines? And what do you think that tastes like? And the point I'm making here is very often we prescribe medicines for a patient and we just put normal tablets and capsules down and we don't think about the person administering it. And I believe the person who was administering the medicine was trying to do the best by the patient. They were told that's what they had to do. They were told they had to get the medicine into the patient. And therefore, in their mind, the best way to do that was to do this. Crush them up, add some water, and then feed the patient. And what shocked us was we saw patients actually being sick or looking as if they want to be sick whilst they were taking these medicines. So what we need to do is think about alternative approaches, different ways.
Okay, that's just an excerpt from the online course, which is a massive open online course, absolutely free, with Future Learn, Medicines and Dysphagia, if you want to know more about the topic. So what I say is, you've got this person who needs their medicines. First of all, can we just discontinue the medicine? It's not probably what we want to hear as pharmacists who rely on supplying medicines. But I think this, from a patient perspective, may be the best thing to do. At least seek medication review. Change the formulation. Try and avoid the oral route altogether. That may be safer. Or use different types of products. But when you're going to do that, think about consistency. Go back to those swallow and try to figure out what is a swallow, what's the right consistency. And what's come out recently is what's called IDSI. And IDSI is an international index for swallowing, and it's to basically set the texture of the medicine or the food and liquid. So it's kind of the idea is everybody in the world has this scale, and then they know, so this person needs IDSI 4 or IDSI 6. And one thing I've been trying to do is get liquid medicine manufacturers to actually put this scale on their medicine so that actually people know whether it's safe or not. And the reason they won't is because they're worried if they say the liquid's IDSI 5 and the patient needs IDSI 6, they won't prescribe the liquid. And what they need to do is actually they say, well, to get to IDSI 6, you do this and this, and it's a lot of extra work. So there's almost a reluctance by pharmaceutical industry to actually adopt this scale because that might mean they reduce the number of prescriptions for their medicines. And we have to then go down to the crushing or dispersal, which is always the last option. My recommendation is, is this going to be safe? Seek advice from someone who knows. Don't just do it because you've seen other people do it. And once you do that, make sure you've got the right consistency. So here's a question for you, another one. Is it safe to mix medicines with thickeners? I have absolutely no idea. There is no evidence to support doing so. There is evidence to suggest that they can stop medicine being absorbed. Is it safe not to? Probably if you monitor for efficacy. Have a go. Okay. They're all right. There's no wrong answer there, to be honest. So you're right, we have no idea. There's no evidence. People haven't done the trials. So really, for all the medicines you'll see in your normal practice, you can't go and find a book and say, well, this is the right thickener. This is what you should do. There isn't any evidence to support doing so. So you're doing something that's very unevidence-based. But there is a small number of studies in Japan where some guy, I think for his PhD, was looking at thickness of medicines and showed actually they can totally bind the medicine up. So it was a diabetes treatment that was that I saw, which basically once they took it with a thickener, the drug had no effect. The diabetes was no longer controlled. But then the next question is, if you don't thicken it up, you're going to have the wrong consistency, and therefore you increase the chance of aspiration. And therefore, is it safe not to thicken? So I would say is my advice is with thickeners is, okay, we don't know what's safe, we don't know what's appropriate. But what you've got to do is monitor. You've got to decide, well, if I'm going to add a thickener, what's the clinical effectiveness I want to see, and is it changed as a result? And it's just somewhat you're going to have to take into account and think about and put in the patient notes so that you can think, well, actually, is that sudden change in effectiveness due to the fact we've added a thickener in? The worst thing that can happen is a thickener is added in and the doctor or prescriber has no idea that's the case. and therefore they think the drug's just not working, and therefore they keep increasing the dose, which is not ideal. So I developed a number of years ago a swallowing aid, worked with a pharmaceutics colleague, because I had this idea that actually perhaps what we should stop doing is give people tablets and water, because that's not great for aspiration. Stop people crushing them. We'll create a gel which you can put tablets in. Now, I know you've got gloops and you've got some different things in Norway, because I've got them in my office. But I developed this gel to put the tablet in. And the idea was it would lubricate the tablet, it would hide the taste, increase the size so it was easy to manipulate, it would hold together, but would dissolve in the stomach and less likely to aspirate. And actually, it was easy to swallow. And having used this and in the trial we definitely found that it did make tablets much easier to swallow. You did need water with it. It took us 5 years to get to this point. We then got a big grant from the government, and then I went and said, right, let's do a proper trial now to show that this is a good product. And this was my retirement fund. We worked for many years. I had this great novel idea. I was going to develop a swallowing aid, and then I thought I'll clinically test it, and then I can really sell it. And we got patents for the product across the whole world. It was innovative. Nobody else had done anything like this. We got Europe, Japan, China. You know, we spent thousands of pounds at the university, but I had got a big grant to do the trial. And unfortunately, we found it actually affected the absorption of the drug, and therefore it was unsafe. It only had HPAMC, hydroxypropylmethylcellulose, in it, some citric acid, water, and gelatin. That was it. There was nothing else in there. They were all safe products. They were all commonly used in pharmaceutics, but actually combined, they reduced the absorption of the aspirin. Not only did they reduce the absorption of the aspirin by about 20%, but they equally reduced the effect on platelets. So the platelets became no less sticky. So they had a negative clinical effect and obviously a negative pharmacokinetic effect. And therefore, the product was not safe. But what's interesting is all those products that are out there, the thing you have in Norway and all the other ones that are across the world, no one's ever done a trial. No one's ever tested to see whether they affect the absorption of the drug. What they do, and what I should have done, I'd be a rich man now, was they actually just get a group of experts in a room and say, well, look, these are our ingredients. Do you think this is going to affect the drug? And the experts say, no, that looks fine to me. And therefore they then get a license, because they get a medicinal license, not a medicinal license, a device license rather than a medicine license. And a device license requires a much lower level of evidence. But because I wanted to check my product was safe and demonstrate good quality evidence of effectiveness or not effectiveness, I stupidly did the trial, proper center and everything. And obviously the patents have all gone, and I'm no longer retired, and I'm still teaching you from my bedroom at 7 o'clock at night. So just to come back, why I'm talking about that is because actually thickeners have a lot more stuff in them than my simple gel. So my guess is that if my simple gel stops aspirin absorption and makes it less effective, then thickeners probably do as well to a certain extent. And my guess is they probably delay the absorption and they can reduce drug effectiveness. But it is the only safe option. So really, if someone is using a thickener, you've got to have monitoring plans in place. You've got to decide what you need to watch out for and check that the drug's working just as well when it's thickened than when it wasn't before, because it's the only option available to you. So just to summarize what I've said, I think we've covered 50 minutes quite nicely there. Dysphagia creates medication errors. Just by having dysphagia just makes life a lot more difficult. People have to make difficult decisions. Once you've got dysphagia, you've really got to think about the medicine, the route, the formulation, and the consistency. You've got to think about the legality of what you're doing. If you're crushing tablets, you're not authorized. But the other issue with crushing tablets and mixing them in with food or stuff is then you're being seen to do covert administration, i.e. giving people medicines without them knowing about it, which is majorly controversial and can get you in severe trouble as a healthcare professional. So hopefully you'll see why I say to everybody, seek a pharmaceutical advice prior to crushing. We are the pharmaceutical experts. We do all that lab work to give us that knowledge so that when people ask us a question, it's something we can add to the knowledge base and we can add to patient care. We can also say what the options are. Because we work in dispensaries very often, we know what all the products are available. So actually, there's a dispersible, or actually there's a liquid, or actually there's this. Things that nurses and doctors may never come across because their experience of medicines is limited to what they prescribe. And if you're going to crush and mix with a thickener, you must monitor. So, last quiz question for you. I'd like to ask for the end of this, what's your main learning point that you've taken away from my 50 minutes? I should put F, don't invite David to give a talk. Puts me to sleep. Okay. Most of you had a go at that now. Yeah, and you've all chosen different things. And I don't really mind what you take away. It's really up to you what you think's important. I think the, not realizing the effect it has on errors is quite important for us as pharmacists. The formulation tampering, I think you're probably all aware of. We know it's dangerous anyway, most of you. Yeah, as your pharmacist, then you would totally agree with that people should be asking you, and this should be one of those questions you can confidently answer. And they're thinking about thickeners, and people don't think about thickeners. They don't think about using them in the first place, and when they do use them, they don't think about the impact that has on the medicines. But just to finish off, just to say, so I can share the slides, but I've developed guidelines for a number of things nationally, not just on dysphagia generally, but with people with learning disabilities and people with enteral tubes. And I was also on another group which was for children as well. So there's 4 sets of national guidelines we have in England. They're totally optional, but they're freely available from this website, which basically tell you sensible, common sense advice that you may want to give. We have the massive open online course, and basically all that course has come from my book, so don't bother spending money on my book. The royalties I get from my book every year come to £14, so I'm not getting my foreign island based on that. And I kind of say on the course, don't buy it, you'll get everything you need here. I do have a website, swallowingdifficulties.com, and if you go to that website, you can type in the name of the drug that you're interested in, and it'll tell you what's available and whether it's safe to crush it or not. So that's something I've had now for about 6 to 8 years. I have about 4,000 people a month using that website, and it's generally aimed at patients and their carers to help them see whether they should be crushing their tablets and whether they should be asking for something else. I also have an app called PharmaQuest, which again is free, and again it's like a little drug guide for students, and it tests them and develops their knowledge about drugs. But actually within it, it also mentions about whether it's safe to swallow tablets or not, or crush tablets or not. Okay, thanks very much for listening.
Thank you, David, for a brilliant lecture and a very informative lecture. So I asked the audience, if you have any questions, you should unmute yourself. That means you should click on the microphone symbol. So please forward any questions that you like.
We didn't get any in the chat. No, that's okay then. That's an easier night for me. I'm happy to answer any questions anybody's got on the topic. Stunned silence. Ah, good. Yes, it is. So thanks, Tanya. So yeah, modified release, there's many different words used for it, but prolonged release is exactly the same. And generally we prolong the release so that we only have to give the drug less frequently. And if you give it less frequently, you have to have more doses in there. So modified release, prolonged relief, extended release. There's a whole range of different words that manufacturers use to say basically the same thing. Yeah. Don't crush them. And if someone's chewing them, then think about giving them the normal release more frequently rather than giving them a modified release to chew. Anybody else? Okay, I've got football on at 7:30. I'm happy to finish a bit early. My football team are in the European League.
Okay, it doesn't seem like there are any further questions. That means that you had a crystal clear lecture.
I wish.
So thank you, David, and thank you to the audience for showing up.
Thank you. Nice to be back in Bergen, if only virtually rather than really.
Definitely. So I think we end our meeting now.
Thank you.